Assalamu alaikum and good morning. Today we'll talk about diabetes mellitus, how to screen it, how to diagnose, and how to examine a patient with diabetes, how to take a history and examination, and of course assess the diabetic control in a patient who is already diabetic. Now, since diabetes can be present asymptomatic state for quite some time before it's diagnosed, so it's important, and it's also important that the complication of diabetes may be prevented if you diagnose it early and if you start treating it early. And many a times, by the time the diabetes is diagnosed, patient has already had some complications. Many a time we have seen patients with acute myocardial infarction presenting emergency room with first time with the infarct, and at that very time the diabetes is highlighted or diagnosed for the first time. So had it been suspected earlier and had it been diagnosed early, the patient might have been saved from this major catastrophic complication. So we must screen the patients for possible occult diabetes, or we should possibly be predicting that these are the individuals who are likely to develop diabetes later on, and some change in their lifestyle, diet, and exercise may either prevent diabetes or at least delay the diabetes onset. So would be the complication associated that will be delayed. So, as we know that most of the patients are asymptomatic and they are unaware that they have diabetes, and a widespread use of fasting plasma glucose as a screening test for diabetes mellitus may be implemented and can diagnose many a patient at a very early stage. Type 2 diabetes may be present even up to a decade before the diagnosis, and some of the, as we already mentioned, 50% of the diabetics have complications, and but they don't know that they have diabetes. And any treatment started earlier may favorably alter the natural history. Who should be screened? I think that all patients over the age of 45 years must be screened for diabetes, regardless of presence or absence of family history of diabetes. But those who have additional risk factors, cardiovascular disease risk factors, they must be screened even earlier on, and they should be screened more frequently. So individuals who are 45 year age or plus, they should be screened every 3 years. Individuals who have additional risk factors like hypertension, obesity, we'll talk about, they should be screened earlier, and they should be screened more frequently. Who are those patients who are at risk of developing diabetes and who should be screened earlier? Obese patients who have a BMI of more than 27, or who have more than 120% of their desired weight. Those who have first degree relative with diabetes, anyone who has hypertension, like a blood pressure recording of more than 140/90 millimeter mercury. Those who have low HDL, less than 35, or high triglyceride, above than more than 250. Those who are physically inactive, those who don't walk at all, and if they have previously been identified to have impaired fasting glucose or impaired glucose tolerance, they must be screened earlier. Similarly, all women with history of gestational diabetes at delivery or delivering a baby more than 4 kg of weight must be screened earlier and more frequently. Ladies with polycystic ovarian syndrome or Acanthosis Nigiricans, both conditions leading on to insulin resistance, must be screened earlier. And anyone who had a history of vascular disease, anyone who has had a stroke or myocardial infarction or a peripheral vascular disease, must be screened for possible diabetes at an earlier age and but more frequently, maybe every year. For type 1 diabetes, screening is probably may not be as useful or as fruitful, because these patients are usually have a marked hyperglycemia, and asymptomatic hyperglycemia is relatively infrequent in them. Similarly, though there are immunological markers available, like we talked about the antibodies like GAD antibodies or other antibodies, which may be pointing that the patient is at a risk of developing type 1 diabetes, but still routine say screening for type 1 diabetes is not very favorable or not very recommended. Similarly, there are no benefits provided with if you say diagnose them early and you start treatment earlier on. Now, that was about screening. Then about the diagnosis, that what should be the cutoff values of blood sugar level which should be considered for a possible diagnosis. ADA in 2016 gave these guidelines, which are still in vogue. If someone has symptoms of diabetes, which may be including polyphagia, polyuria, polydipsia, or a weight loss, and has a random blood glucose level of more than 200 milligram, it is sufficient to label him, maybe doing the test at least twice and then labeling him that the person has diabetes. Or anyone who has a fasting plasma glucose level of more than 126, or who has an HbA1c of more than 6.5, or a 75 gram oral glucose tolerance test 2-hour value of more than 200 milligram. Now, as you can see, any one of these may be considered as a possible diagnosis of diabetes mellitus. For fasting and random glucose levels, it is recommended that they should be repeated at least twice. That on 2 occasions, if you find a fasting sugar of more than 126 or a random sugar of more than 200, it is sufficient to diagnose. In someone with random levels, maybe in between 140 200 post meal or 100 to 126 fasting, may be considered diabetic if their HbA1c level is more than 6.5. Oral glucose tolerance test is not nowadays routinely used for diagnosing the diabetes mellitus, but sometimes it does have value in patients who are on borderline, who have normal or near normal fasting glucose level, but suspicion of diabetes is high. So then oral glucose tolerance test must be implemented, and same way it is probably more appropriate to do it in to diagnosis for gestational diabetes mellitus. As I already mentioned, that each one of this reading should be at least confirmed by a repeat testing on a different day. Fasting plasma glucose level is quite reliable and convenient test for diagnosis in asymptomatic individuals. Diagnosis may be withdrawn in situation where fasting plasma glucose returns to normal. There are 2 new categories which must be familiarized. We use the term impaired fasting glucose as well as impaired glucose tolerance. What they are? Impaired fasting glucose is based on fasting plasma glucose level, and you may have 3 categories of these patients. You may have a normal fasting plasma glucose if blood sugar level tested in fasting state is less than 100 milligram. The fast has to be around 8 hours, that the person should not have taken any meals for previous 8 hours. You diagnose diabetes mellitus as just mentioned, that if blood sugar level fasting state turns out to be more than 126. But those individuals who have a blood sugar level between 100 to 125 milligram per deciliter, they are labeled as having impaired fasting glucose, and these are the individuals where oral glucose tolerance tests should be performed to rule out diabetes. The other category is patient having impaired glucose tolerance. So plasma glucose values between 140 to 200 milligram per deciliter, 2 hours or within 2 hours of oral glucose tolerance test, which is given 75 gram of glucose, they are labeled as having impaired glucose tolerance. But those who show of more than 200, they would be labeled as diabetic. Both impaired fasting glucose and impaired glucose tolerance are comparable as far as the long-term risk of developing frank diabetes is concerned. There is 40% risk of developing diabetes mellitus type 2 and cardiovascular disease in patients who have either impaired fasting glucose or impaired glucose tolerance test. An important thing is that a modest change in lifestyle may reduce the risk of development of frank diabetes in these individuals. And they may be started on treatment with maybe treatment sometimes, and maybe just on diet and exercise alone, and they should be again annually screened for development of diabetes mellitus. Now this comes to care of a diabetic patients. Once you label someone to be having diabetes mellitus, or you are examining a patient for any other reasons in a medical floor or a ward or in OPD who already has diabetes. So this is the things which we probably have to keep in mind and follow that what should be done with them. So you have to have an initial evaluation. You have to look at how they are being managed. You have to look after about medical nutrition therapy. You have to train them or educate them for self-management of their diabetes. You have to counsel them for physical activity and the type of physical activity they have to carry out. You have to emphasize the importance of glycemic control and how that glycemic control is to be monitored and achieved. Of course, they would require some psychosocial assessment and care as well. Right? Sometimes this diabetes is taken as a stigma. Sometimes this diabetic patient, the news that the patient has diabetes at least is taken as a very, very serious thing being happening to the patient, and the patient may go into depressive illness or may show a lot of anxiety of how they would cope with it. They have to be trained about that when they developed some intercurrent illness like any respiratory tract infection or UTI or other problems. So what do they have to do with their diabetes management, and whether they have to stop medication or increase medication, or this is called as sick day rules, that on sick days what has to be done. And most importantly, these patients must be made familiar with hypoglycemia and the risk of hypoglycemia and how to prevent it and how to treat it. Starting with the initial evaluation, after knowing that the patient has either type 1 or type 2 diabetes, this is the plan I usually tell our student to follow, that you have to assess 4 C's. The first C stands for the compliance of your patient, and that compliance means that your diabetic patient is compliant to or carrying out the desired or advised physical activity. Is he compliant to the dietary restrictions, being what to eat and what not to eat? Is he regularly following his medication, whether it's an oral hypoglycemic agent or an insulin, and whether he is regularly taking that as well? And after that, we have to assess the second C, which is control and monitoring. Is his or her blood sugar well controlled according to the parameters already given? Or does he or she regularly monitors it, his blood sugar level? And if so, what mode of monitoring is being practiced? We have to assess that is it diabetes alone, or patient has some other comorbidities or other illnesses along with it, like he may have hypertension, he may have lipids or dyslipidemia or high cholesterol level, he may be obese as well. So all these factors may modify your approach towards management and maybe making your patient more at risk of developing complications. And then finally, the final C is whether not this patient already has had some complications of diabetes, like macrovascular complication in the form of stroke or heart attack or perivascular disease, or a microvascular complication in the form of retinopathy or nephropathy or neuropathy. And of course, you have to talk about in terms of symptoms of these rather than asking your patient that do you have a macrovascular complication or do you have a microvascular complication. And again, the last objective of our patients of initial evaluation is that we want to educate the patient, not only the patient, but his caregiver, that who is the patient may be quite an elderly person who may not be able to inject insulin, may not have, say, may have some visual impairment and may not be able to recognize which medicine he is taking, and he is dependent on some caregiver, which may be a wife, which may be daughter, which may be son, and they are the one, or maybe some say healthcare worker. These have to be trained and educated both the patient and the caregiver. Similarly, the initial evaluation of your patient would start from a history, a physical examination, some laboratory evaluation, and then of course you also have to know that when and where to refer a patient when he develops some complications, like what does he do when he has a skin and soft tissue infection, what he does when he has a diabetic foot, or when he had acute surgical complications. So this is again equally important, when to refer to nephrologist, when to refer to ophthalmologist for any eye complications or retinopathy. So this must also be discussed and explained to your patients. So this is the sort of algorithm that when you take a history in a patient with diabetes, you have history regarding illness, personal history, his family history, social history, and then we'll go one by one. That in history regarding illness, we already talk about that. We talk about diabetes type and duration, control, what drug is taking for, complications, compliance, education, and of course comorbid. This we had discussed earlier. Right, about the type of diabetes and then the glycemic control, and then right. The type of diabetes we already know, it can be type 1 or type 2, and then there are secondary causes we discussed in the previous lecture, some pancreatic diseases, endocrine diseases, some drugs may lead on to, we touch a little bit about maturity onset diabetes of young, and we also talked about rare type forms of diabetes like late onset diabetes, autoimmune diabetes of adults. So from a history, how can you judge the type of diabetes, or what type of what is maybe the difference in various patients with whether with type 1 or type 2 diabetes? So usually we talk about onset of symptoms at diagnosis. Many of the patient may have noticed weight loss, they may have noticed polyuria, they may have noticed polyphagia, they might have noticed recurrent skin and soft tissue infections at the beginning, or they may be, as I said, the first manifestation may be some kind of a major cardiovascular complication or macrovascular complication. Knowing about that, what was their weight prior to diagnosis, whether they were obese or they were already, say, having less weight is important. Type 2 diabetics are, majority of them are overweight, and type 1 diabetic, majority of them may be having low weight for their height or for their age. What was the blood glucose values when patient was diagnosed, and whether there was any ketones reported or detected in the urine at the time of diagnosis, which is usually more commonly seen in type 1 diabetics. What kind of methods they are using for their glycemic control? Are they on oral hypoglycemic? Are they on insulin? Or they are diet alone? Or they are exercise alone? So that's also important to know. Do they require insulin, say, for survival? Like as we discussed, that patient with type 1 diabetes may be having, say, lifelong dependency on insulin. And similarly, patients in type 2 diabetes may have gone on to a stage where only insulin is controlling their blood sugar, and the rest there is a failure of oral hypoglycemic agents to control their diabetes. We have to look into whether they have any other autoimmune diseases with them or not. Family history of having diabetes in first degree relatives or other family members is important. And sometimes you do ask about symptoms of abdominal pain, malabsorption, Cushing, acromegaly, which may be suggestive of an coexisting other autoimmune or endocrine disorders. Then we go on to that what glycemic control is to be achieved, and how it is achieved. So we talk about history of glycemic control, how this patient is monitoring his blood sugar. Patient may be using glucometers and this sticks for using monitoring their blood sugar levels. They may be just getting lab blood sugar checked from the laboratory with the whole blood, right? Or maybe in fact the glucometer will be checking the whole blood, and the laboratory will be checking the plasma. With there is hardly a 7% difference in the two readings, whether you check it on plasma or on whole blood. Sometimes they may just be following glycated hemoglobin level every 2 or 3 months for checking their control of blood glucose. You also have to ask about any symptoms pertaining to hyperglycemia, like ongoing osmotic symptoms in the form of polyuria, polyphagia, and weight loss suggest patient is having persistent hyperglycemia. Sometime he might have been admitted with hyperglycemic crisis, like maybe hyperosmolar non-ketotic coma, or maybe for type 1 it may be diabetic ketoacidosis. And sometime, and probably the most important thing is to know about hypoglycemia. Right? You have to know about if they have experienced hypoglycemia at any stage of their illness. If so, what was the duration, how frequently it occurs, how severe it was, whether it was documented or not, how was it relieved, whether by intake of oral glucose or some sweet objects, or he had to be injected 25% glucose. And of course, what is the dietary pattern? When does he develop hypoglycemia? Then you talk about the complications, right? Again, we'll have a full session on complication, acute as well as the chronic complication of diabetes. But as we grossly group them, we group them into microvascular complication, macrovascular complication, non-retinal ocular complication in the form of development of cataract, and in the form of development of glaucoma, and but more importantly, the retinal complication, which we usually had under microvascular complication, the diabetic retinopathy. GI complication in the form of vomiting, early satiety, abdominal distension, diarrhea, or constipation of all sort may be there. Musculoskeletal complication in the form of muscle weakness or wasting or inability to bear weight, or proximal myopathies. Infective complications, skin and soft tissue infections are more common, and of course neuropsychiatric complications. And you may also add that both combination of micro and macrovascular complications, and to add to it this neuropathic complications may lead on to more development of diabetic foot ulcers or diabetic foot complications, or diabetic foot per se as a complication. Another important aspect of managing diabetes in total is that you have to educate your patient. Not only the patient, but the caregivers as well. So we probably have to assess your patient at how much knowledge he has about his disease and about his importance of its management and importance of its control, right? Does he know that what are the blood sugar level targets for him, that what should be his ideal fasting blood glucose when he is having diabetes, what should be his 2 hour post meal value, what should be the value of HbA1c if his sugar is well controlled or not. We also have to assess as well as educate them that at what time they take their oral hypoglycemic agents, right? Some of them might be taken before meals, some of them they have to be taken with meals, some of them may be after the meals, and then how soon before or after the meals to have their maximum benefits, that has to be explained and told to your patient. If they are using insulin, do they know that how to store insulin, whether it is in to be stored in refrigerator at what temperature, and those with no say electric supply or does not have any refrigerator for one reason or the other, or low socioeconomic group, they have to explain that whether it can be put in a mud pot or what we call as a say ghade mein. And again, those who store it at in the on the refrigerator, it is also important to tell them that before injecting this insulin has to be brought to a room temperature, not injected as such at 4 degrees centigrade temperature, which is maintained in refrigerator. It has to be brought to the room temperature before being injected. Those who are using mixed insulins, like there are pre-mixed insulin where you have a mixture of regular insulin or short-acting insulin plus longer-acting insulin in the form of 30-70 combination. But sometimes they are using insulins which are in 2 different vials. One different vial of plain insulin or regular insulin, and another vial of NPH insulin or long-acting insulin, and they are asked to mix the two in a certain combination before injecting. And it has to be explained that they first have to inject or fill their syringe with regular insulin or short-acting insulin, and then they have to say add insulin from the longer-acting one. Doing it in a reverse fashion might convert the regular insulin to a longer acting insulin because of the mixing up of the injection in the vials. They have to explain the timing between meals and injection, that how soon before the meal this has to be injected, and what has to be the time interval between the 2 consecutive injections or 2 injection dosage. They have to explain about where to inject and the importance of keep on rotating the site of injection. Usually we inject it on their abdomen or into the subcutaneous tissue in the belly. The technique of injecting insulin is important. What should be the angle of say syringe or needle with the skin? How should skin be held in the skin fold? Should there be a bleb formation of injection or not? And then of course how much time should pass? When should they change their insulin syringe or needles? Now each and every step of this needs to be explained to your patients and individuals, and of course that is the job of what we call as the diabetes educator. And you yourself have to be your patient's educator. The most important thing in patient with diabetes is to make them aware of hypoglycemia, hypoglycemic care. They should be told or explained at least once. In fact, they should be made to experience hypoglycemia once in their session on their diabetes education. And then of course they have to be told about that how much glucose has to be taken. They have to keep some sweetener with them in the form of candies, etc. Right? And then, as we already discussed, that what to do when they get sick. They have fever or infection, and should they stop their oral hypoglycemic or should they stop their insulin? How much fluid they should take? these infections can precipitate, say, a state of ketosis, and should that be monitored along with it or not? This is all part of, say, diabetes education, and the team which is taking care of these patients must be accessible and must be, say, contacted, and they should know when to contact their, say, diabetic team for any change in their treatment plans. It's equally important to make them aware about complications, and they should be told that what complication would have what symptoms, awareness regarding all the complicated diabetes and their relation to glycemic control. And of course, they should be emphasized upon that a good glycemic control can at least prevent the complication, sometimes reverse the complication, or at least may lead on to some arrest in the further aggravation of those complications. And these complications, if they develop, they should be periodically monitored, whether they are stable, static, or whether they are further complicating. Foot care is a total, say, as I said, one major component of management of diabetes, right? So the type of footwear and socks, they should be avoided bare walking. They should be told about care of their foot. Similarly, pregnancy during, well, in diabetic patient, those who are already diabetic and they wish to have conception and planning pregnancy, they have to have a pre-pregnancy blood glucose targets, A1C goals, and if there are risks involved, they should be told about contraception methods as well. Now, this is about the history in diabetic patients, right? In addition to that, we also have to look into some personal aspect of diabetic patients, which may be important in the long run for his management. We have to look into some family history and social history as well. Talking of the personal and lifestyle, we have to know the type of food patients prefers, and what is the usual his routine, at how many times does he take food, how many times does he take snacks. Then of course you have to explain about calories, carbohydrate and protein in diet, and their counting. Carbohydrate counting is now being practiced, that they should know that how much energy is coming from carbohydrate, how much from protein, and how much from the fat and the sources. Similarly, you may have some people who are non-vegetarian, and their the what we call as a meal plan has to be titrated accordingly. Which type of milk they are using? Are they using artificial sweeteners or not? Food exchanges, that if they want to take a certain type of food with a certain number of calories, and that is high rich in carbohydrate, how that can be exchanged with something which is low in carbohydrate but have similar caloric values. They should be having an adequate amount of fruit and vegetables in their diet. The amount of oil and ghee used per month per member of the family can be calculated from their kitchen, that how much do they use in a month, and how many family members they have. Their physical activity at the workplace, what are their leisure activities, do they have an habit of having some games or some say regular walk or exercise, and what is their exercise pattern. They do go just a simple walk, or do they go for very strenuous exercise like the gym or weight trainings. In family history, since type 2 diabetes particularly does have a tendency to run in the families and is inherited, it's important that how much earning the person in question or patient has, and how many family members are dependent on him, so that we can assess that whether he will be able to afford is treatment or not, and some kind of a social welfare assistance has to be looked for or arranged for him. Definitely, these patients do need emotional support, particularly in some time of complications or acute illnesses. Explaining to them the lifestyle changes, particularly the young family members who are possibly not diabetic yet are likely to have. So it's you manage not only the patient, but you also manage the family, and of course you are attempting to prevent the diabetes in the rest of the family members or the next generation as well. Then again, the type of work person does, whether he has to go to school or university or his workplace, the workplace is an office desk job, or whether it involves heavy strenuous exercises, because that will say affect the choice of medication, the timing of medication, choice of meals. That all is very important to know. Then again, information to responsible person regarding the disease, like a type 1 diabetic going to school, his or her teacher must be aware that he is diabetic and needs special attention. He might be developing hypoglycemia at some stage when he is not responding to her answers correctly, right? And when he is feeling low. Similarly, how to carry insulin with them when they are in travel or when they're going for their work, where they might have to inject insulin in the midday at their workplace. Then there are stigmas regarding injection, that someone they are say shy of injecting insulin, or in fact shy of being known that they are diabetic and they are on insulin or medication, and that is one reason that many of these patients do not get a very stable glycemic control, because they do miss their injection or dosage because of sheer say shyness, or not letting other people know that they are possibly diabetics. The examination of diabetic patients, of course, should start with, first of all, the anthropometric measurements. You should know their height, weight, BMI, and waist-hip ratio. The journal examination must not omit at least examining their peripheral pulses, checking for their postural drop in blood pressure, examination of their footwear, skin and nails, and of course looking into genitalia or asking about erectile dysfunction. They may have nephritis in men, testicular atrophy, and sometimes they may have hemochromatosis along with it, which may be one of the factors responsible. This is how the waist should be around measured at the level of around upper say anterior superior iliac crest level, right midway between the lower rib margin and the iliac crest, with the tape all around the body in a horizontal position. This is checking the neck circumference. That is again equally important. Neck circumference greater than 16 inches in a woman or greater than 17 in men correlates with increased risk of obstructive sleep apnea, and this is again one of the factors in insulin resistance as well. BMI of more than 25 kilogram per meter square is called as overweight, but someone with it more than 30 would be called obese. Normal waist circumference in male should be less than 1 or 2 centimeters, and female should be less than 88 centimeters. A normal waist-hip ratio in men should be less than 0.095, and those having a more than 1 waist-hip ratio are at risk of developing diabetes, or in fact this is one of the common metabolic syndrome. A female with a waist-hip ratio of less than 0.8 have a low risk, but 0.85 are considered to be in high risk for development of metabolic syndrome or diabetes. This is an example of Acanthosis Nigiricans, which is related with insulin resistance. Right. This is again a few other sites like in the axilla or on the skin where you have to look for this Acanthosis Nigiricans. This is Scleroderma diabeticorum. Repeated injection of insulin leads on to thickness of the skin, and skin cannot be pinched. Vitiligo may be associated with the type 1 diabetes mellitus and may be associated with the Addison along with that. Diabetic dermopathy, look at the nails. There are fungal infected nails, and there are so many scar marks over the chins, suggesting a previous recurrent trauma or say other neuropathic complications. Sometimes this diphtheria contractures or flexion deformities of these long tendons may be associated with diabetic neuropathies. In systemic examination, in cardiovascular, as I mentioned, always palpate all the peripheral pulses, particularly dorsalis pedis and posterior tibial arteries, auscultate for carotid vertebral bruit, and if available, do check for ankle brachial index, which is the measurement of systolic ratio of the systolic blood pressure at the ankle to the arm. In neurological examination, you must check for cranial nerves. If there are symptoms, the isolated single cranial nerve policies or multiple in the form of monoid multiplex is not uncommon or unusual. Dorsal column tracts to be checked for primary sensations like large fibers, soft touch, vibration, proprioception, joint position, and of course spinothalamic tracts which are small fibers for their pain, temperature, pressure, and crude touch. Peripheral nerves may become thick and palpable. The patient may have cerebellar signs which will be checked in. Look for vitamin B12 deficiency, or which can be as a result of concomitant intake of metformin, which leads on to low B12 absorption. And sometimes you must examine the retina or fundus of this patient for looking at the vessels directly. This is how you check for the vibration sense. This is a normal fundus in a patient who is not having diabetes or does not have at least diabetic retinopathy present. Look at it. This is the quite advanced form of proliferative diabetic retinopathy. Not only you can see a lot of vessels, but you can see hemorrhages, you can see exudates, and you can see this macula being surrounded by exudates. Majority of these patients do have a liver enlargement, type 2 diabetic particularly, because the fatty liver is part and parcel of diabetes, and liver has to work more to produce glucose or works as a gluconeogenesis. So there is some hepatomegaly is almost there. Renal artery blue can be auscultated, particularly in those diabetic or uncontrolled hypertension. Respiratory system may look for signs of consolidation, which may be that these patients are more at risk of developing tuberculosis and may already have some, say, active or residual or previous tuberculosis. Then you have to monitor the level of glycemic control. That if self-monitoring is practiced, whether it's episodic monitoring by glucometer or a continuous monitoring, regular fasting post-prandial glucose being checked. Whether this long-term assessment is checked through measurement of HbA1c, or sometimes you may check for fructosamine for a rather short-term control. A1c gives a measure of around 4 months, fructosamine gives a measure of around 1 month, and sometimes glycated albumin may also be checked. The self-monitoring of this blood sugar has revolutionized that we do have day-to-day information about the trend of glycemic control. This makes your patient an active participant in his care. You can rapidly adjust the treatment or adjust the dosage of insulin there and then, and you can reinforce the dietary changes by looking at the glycemic control chart, whether in which direction they are going. And it is, of course, more useful tool in period of stress and patients who are susceptible to hypoglycemia. So it can be early, say, confirmed that the patient is having hypoglycemia with self-monitoring of glucose. It has its value if it is performed on regular basis. Of course, you use the measurement accurately and make use of those results. It is not just that you just record and forget about that what the reading was. You probably have to adjust your patient's levels accordingly. This can be done on daily basis before meals and bedtime wherever symptoms occur, or it can be periodic, maybe 90 to 120 minutes after the meals, and sometime maybe occasionally you may also check 3 a.m. reading for any nocturnal dip or early morning hypoglycemia. There are no clear guidelines about how to and when to monitor. It can be more frequent when you start the treatment and after changes in therapy. It should be done more frequently. And then, of course, times of suspected altered metabolic control. The patient on insulin therapy should have daily testing, usually before breakfast, dinner, and bedtime. Those in diet therapy may learn self-monitoring to prevent metabolic decompensations through periodic monitoring as well. Continuous self-monitoring is definitely optimizes the metabolic control and minimize the glucose excursions, and of course eventually replace the episodic monitoring as they become more reliable and convenient. The long-term control should be assessed through A1C, which is gold standard, and index of glycemic control over previous last 6 to 12 weeks, and the normal value should be less than 6. A1C has its limitations. It can be falsely low in patients who have anemias like high RBC turnover, and the lifespan of RBCs is shortened. In pregnancy, hematocrit and hemoglobinopathies, there may be falsely low levels, and sometimes it may be falsely high levels in those who have high level of HbF, fetal hemoglobin, like in thalassemias or using aspirin or in uremia. It gives a measurement of about maybe 6 monthly, and sometimes you go for 3 monthly estimation if you think there is inadequate control, or you want to change the therapy, or patient with type 2 diabetes, type 1 diabetes mellitus. Roughly, you can estimate that if someone with a 6% A1C has been having an average blood glucose of 135, 7% it was having an average blood glucose of 170, and 8% was having 205. Your average level has to be around 140 or 150, which it turns out to be around A1C level of 6 to 6.5. And note that 1% rise in HbA1c translates into 2 millimole rise in glucose, or maybe 35 milligram per deciliter in mean plasma glucose levels. Now this ends us with the screening and assessing the patients, evaluating what to talk about in history, in taking history of these patients, how to assess their control, how to assess them regarding their self-monitoring, diabetes education, and what target you give to your patients. And the next lecture we'll be talking about management of diabetes. Thank you.